and then we'll take up 3 minutes of discussion. To help him be on time, we have a timer straight across. Over to Professor Bhuwan Tiwari.
Good morning, chairpersons, expert panelists, all the doctors available present in this auditorium. So today I have to speak on refractory and secondary hypertension. These both two topics are very vast. To cover in this time, it will be difficult. So I am starting with refractory hypertension. I will go through the approach of refractory hypertension, and then in between I will come for evaluation of secondary hypertension, and then I'll progress. So it is defined as uncontrolled hypertension despite use of 5 different classes of antihypertensive agents, including a long-acting thiazide or a thiazide like diuretic and a mineralocorticoid receptor antagonist, spironolactone. Usually some studies have said the timeline for this definition to come is that at least trial of 6 months over 3 visits over a period of 6 months to define this term. So now the prevalence is much rarer than the more common form of resistant hypertension. It varies from 0.5 to 1.4% of all hypertensive patients which are diagnosed, and it is 5 to 10% of patients with resistant hypertension. Now in India we don't have any data for this, but some studies have shown that the prevalence of general hypertension in adults is around 29.8%, more in urban and slightly less in rural. And the level of control of blood pressure are very low in our country, approximately 20% for urban population and 11% for rural population. So seeing this level of control, we would have, seeing our large population, we will have lot of cases of refractory hypertension. So it is seen that heightened sympathetic tone is a major mechanism behind refractory hypertension, as evidenced by increased heart rate, reduced heart rate variability, etc. And while excess fluid retention is an important mechanism behind resistant hypertension, but these both overlap significantly with each other. They are not specific for one of the. So who are the patients we get to see? Usually they are younger, more often they are female, higher heart rate, a baseline heart rate, higher 24-hour mean BP, heart failure is seen more often. While other comorbidities like diabetes, CKD, obesity, cardiovascular disease are almost alike in refractory hypertension and resistant hypertension. So the prognosis with ABPM studies have suggested that almost twofold risk of MACE cardiovascular mortality in patients with refractory hypertension. Now, how do we approach a case of refractory hypertension? So we go stepwise evaluation and then come to the treatment part and further. So first step is to exclude pseudo-resistance. This is very important because falsely high BP, we will be unnecessarily treating the patients with over medication. Second is identify and reverse contributing lifestyle factors. Third is discontinue or reduce interfering substances wherever possible. Screen for secondary hypertension. So while going through this approach, when I come to the fourth point of screening for secondary hypertension, I will just briefly go and tell something about secondary hypertension. And then after these 1, 2, 3, 4 have been evaluated and excluded, then the treatment, pharmacological treatment start, though it starts from the beginning, but that is the time we need to step up our treatment. And after that, a referral for some special treatments which are available in case the patient is truly refractory to these medications. So now, first major causes of pseudo-resistance, we have to exclude this. This is inaccurate BP recording, poor adherence, white coat hypertension, under treatment or clinician inertia. So when do we suspect it? There is no target organ damage for high blood pressure level, and escalating therapy results in symptoms consistent with hypotension. So now accurate BP recording. This is the most important step which will decide the patient is whether controlled, uncontrolled or refractory hypertension. So the guidelines and everyone says that patient sitting with legs uncrossed with back, arm and feet supported. So this part, yes, we can achieve very easily. Now the next part, which all of us face in our country, to make a quiet room, ideal condition to be wait for patient sitting 5 minutes in a quiet room before the first reading. Definitely this task is very challenging, and it may not be, we may not get this luxury. And apart from this, right BP cuff is important. Now next is that once we have seen the blood pressure level is high, our recording is accurate, then the next step is adherence. So we may increase the medications we give, but the patient doesn't take appropriate medications, so still patient will be in the refractory group. So it is seen in studies that 42% of patients stopped their BP medication within first year after the diagnosis and the treatment was started. So 42% patient, if they uh, stop or they are not completely adherent on the treatment, so definitely we would get treatment failure and refractory hypertension. Now what are the factors we know, like cost of the treatment, side effect, multiple drugs, complexity of the treatment, many patients are from rural background, they are not very well educated, so they may not understand our instruction clearly. So in those cases we have, but also the cost factor is very important in our country. So single pill combination can help in reducing this, increasing this adherence. So now we have to second step, identify and reverse the lifestyle factors like obesity, physical activity, excessive alcohol ingestion, all low salt diet. This all we need to address. Then discontinue certain factors like patients of hypertension at times are old, they have arthritic problems for which they are taking NSAIDs, other stimulants, or erythropoietin for chronic renal disease. So wherever possible we need to address as much as possible. In some cases if we can stop and avoid, and some cases like erythropoietin is given for renal, we may not be able to avoid. Now fourth step, after the three steps have been evaluated, then the ground for evaluation for secondary hypertension. There are some important causes which are more prominent, like obstructive sleep apnea is important, primary aldosteronism is important factor, important cause of secondary hypertension, renal artery stenosis and renal parenchymal disease. Also rare causes like pheochromocytoma, Cushing's or thyroid disorders. So what should be our approach? Who are the patients who should be taken for evaluation for secondary hypertension? So new onset uncontrolled hypertension in adults, or conditions like patient is resistant to drugs, or abrupt onset of hypertension in less than 30-year-old patient, or a diastolic hypertension in old age patient like more than 65 year, unprovoked hypokalemia. So, or there is some clues like palpitation, sweating, episodic headache. So could be suggestion for pheochromocytoma. These are the reasons where we need to screen. So this is a class 1 indication to screen these kind of patients. And if there is a positive screening test, then we go for the definitive screening test. Definitive confirmatory tests are required after that. So some general clues which we need to have high index of suspicion for finding secondary hypertension cases. So like abdominal bruit will suggest renal artery stenosis, abdominal masses could suggest polycystic kidney disease, paroxysmal headache pallor will suggest like pheochromocytoma. So these are the things we should keep in mind in clinical examination. So now I said obstructive sleep apnea. So this is one of the important cause of secondary hypertension. It is seen that it will be clues like snoring, daytime somnolence, obesity. Then for the confirming test is like the polysomnography can be done, and if it is confirmed, apart from the other medication, we'll have to give a CPAP is helpful and long way to control this blood pressure in these patients. Then comes aldosteronism. So clues are suggested by like hypokalemia or hypernatremia, or mild with low dose of diuretic patient gets severe hypokalemia. So these are the patients to suspect for aldosteronism. Ratio of plasma aldosterone to renin activity is important test. Once the screening test is positive, then we can go for CT scan. After that, once we find that the tumor is present, then we go for a selective adrenal vein sampling and then treatment accordingly as required. For renal parenchymal disease, simple ultrasonography, creatinine clearance can be helpful. And now important cause renovascular disease, we have some suggestions like abdominal bruit is present. Then patient is like, if younger female patient, fibromuscular dysplasia could be important reason for this. or if old patient atherosclerotic renal vascular disease could be an important factor. Those like MR angiography or captopril test and selective renal angiography can be done and further treatment as required. So the list is endless, like pheochromocytoma, we have paroxysmal headache, hypertension, this clue, then we can go ahead with going. And like patient with acromegaly will be giant, with enlarged hand, feet or tongue, visual symptoms, headache, blurring of vision. So these are present, then we can easily screen for growth hormone and go for further evaluation and treatment. Anyway, I don't know some issue with the slide, but anyway, the next step is pharmacological treatment. Step one is, like ABCD rule is there. Initially, we use ACE inhibitor or ARBs, then we use long-acting calcium channel blockers, and a long-acting diuretic like chlorthalidone is preferred. So it has been seen that this is will control in many, and after we exclude other causes. So if this is the first step of the drug treatment, if it does not control, then the second step is according to pathway trial, add mineralocorticoid receptor antagonist, which is seen to be very helpful in controlling the blood pressure. But then issue with this is because many of the patients have CKD and they tend to have hyperkalemia. That is very important issue. For them, we can try adding potassium binders, which will be helpful for them. And some androgenic side effects are there like gynecomastia. So for them, we can try amdoride and epileron. Then next step is because many of the patients are hyperadrenergic, for them the step is adding a beta blocker, preferably which has been proved in trial like carvedilol, metoprolol succinate or bisoprolol is preferred. And then after this, if still not controlled, then we have additional vasodilators can be added. And even if this is not controlled, then we can use the referral for clinical trial, baroreceptor amplification, renal denervation, etc. So the treatment summary for refractory hypertension is effective treatment of refractory hypertension by definition remains unavailable. Current evidence implicating heightened sympathetic tone as a mediator for treatment failure. Sympatholytic agents like clonidine should be beneficial, but use of effective doses is often precluded by intolerable adverse effect. Hence, the effective management of refractory hypertension in future may depend on development of effective and better tolerated sympatholytic compounds, or perhaps use of evolving but still unproven device-based therapies like renal denervation and carotid sinus activation. And my last concluding slide is, we should have in all these patients high index of clinical suspicion is required to diagnose secondary hypertension and treat accordingly. Evaluation of secondary hypertension is important to decrease the risk of refractory hypertension, and assessment of target organ damage, which is independent of the level of blood pressure. Pseudo-resistance and adherence should be addressed because they are the most important and really challenging in our country, our scenario. And lastly, refractory hypertension is uncommon, but huge number of patients in our country who have uncontrolled hypertension pose enormous burden on healthcare services. Thank you.
Thank you, Professor Tiwari. Mr. Chairman, we'll have time for just one question for Professor Tiwari. Thank you.
Dr. Bhuwan, in your clinical practice, which is the three most common cause of the refractory hypertension?
What I find is most important, I feel, is that adherence is a major issue. Second is the complexity of the treatment. Because of that, patient is or cost factor and education. Patient doesn't understand. Most of the time he says, I used to have headache, I used to feel weakness. After medication, I became all right, and I'm now absolutely fine, and I got my BP checked at my places. It is well under control, so I don't think I need to take further medication, so I missed it. And most often these patients are asymptomatic and they come with target organ damage like stroke, CVA or MI. So that is.
Okay, I think that's the time that we have with the permission of the chair. Thank you very much, Professor Tiwari.